All right, for talk number 8, we're going to talk about VA ECMO. We'll go into some indications first. The first is refractory cardiogenic shock. This could be refractory to inotropes, post-op, could be anything. The other big one is cardiovascular collapse of unknown etiology. VA ECMO is preferred in these situations because it will buy us the most time to figure out what's actually going wrong. VA ECMO is a little bit different than VV. So the inflow cannula is still going to be in a central vein. There's still a pump and still an oxygenator, but the main difference is the outflow cannula goes into the descending aorta. So it's a venous to arterial system, whereas VV ECMO is vein to vein system. Settings wise, so it has the same settings. The main difference is that the pump speed is the most important, and his sweep and FDO2 are really there for oxygenation only and to get rid of CO2. So VA ECMO, the problem tends to be cardiogenic, not respiratory. So usually those things they don't matter as much. That being said, if a patient does develop respiratory failure on VA ECMO, having an increasing sweep requirement is not good, because it means that the lungs might be failing. So keep these things in mind. We will talk more about the lung failure problem later. For right now, just know that the pump speed is the most important, and it's going to, in many ways, determine the patient's blood pressure, because the cardiac output is so low of the patient's native heart. So next, we're going to go into the most common configuration, which is right here, and what we'll talk about first. So why don't we go through the cannulas first? So you see the inflow cannula in the central venous system, draining into the ECMO circuit, then going back up through the aorta. That mixing cloud is a key concept in VA ECMO that VV ECMO doesn't have. And so we're going to spend a little bit of time talking about the mixing cloud now, and then we'll kind of have a broad overview of what this is, and then we'll go into mixing cloud complications. But for right now, we like that a mixing cloud to be in the aortic arch at the level of the brachiocephalic arteries. So that's where it's drawn. We like it there because we can use a right upper extremity arterial line to monitor both blood pressure and oxygenation at the same time. So this mixing cloud tends to be somewhere along the aortic arch. The reason why we like it at the brachiocephalic artery, because that is a place that we can know that's the ideal place to check for proper perfusion pressure and oxygenation of the brain. Because if that is the only other place that we can really measure this is in the left upper extremity, and so that would be via the left subclavian artery. So if we had a left-sided arterial line and the patient developed respiratory failure, the brain could be receiving deoxygenated blood, and we wouldn't know. But by putting the arterial line on the right, we will have the earliest warning that deoxygenated blood is going to the brain. Again, this is not common, but it can be catastrophic within hours. So we really want to know. And I kind of put this little formula there that the blood pressure measured from this line is it's dependent on the cardiac output of the heart plus the ECMO flow. And so if the arterial line shows pulsatility, we know that that the mixing cloud is at least near that brachiocephalic artery site. So the arterial line can measure the perfusion pressure to the brain. It can tell us about oxygenation to the brain, and it can also tell us whether the heart is recovering or not. Over time, if the heart has improved pulsatility, we can assume that it's starting to recover. However, if its pulsatility gets worse despite inotropes, the heart is probably deteriorating, and we need to do something different. So this right upper extremity arterial line tells us a lot of information, and we're going to talk about mixing cloud complications soon. We're just going to take a quick detour and talk about kind of the overall concept of VA ECMO. And this is that we have a parallel heart-lung circuit, and if we want to shunt blood to the heart, to the patient's heart and lungs, we need to give the patient inotropes, give them volume, or decrease the flow through the circuit by decreasing the RPMs. If we want to shunt towards the ECMO machine, we're going to diurese the patient and increase the RPMs. So I just put this quick little blurb in here because if you're having blood pressure issues or oxygenation issues, this is how you determine where the blood goes. And then we're going to talk about the mixing cloud complications next. So we'll kind of do almost like a split screen so that we can keep that diagram. And so the mixing cloud, what can happen is that if it becomes too proximal, so it goes between the aortic valve and the brachiocephalic artery, what we'll see is a loss of pulsatility, sudden rise in the right upper extremity PaO2, because this is again pure oxygenated ECMO blood, that its PaO2 will probably be in 3, 4, 500. You might also see LV dilation, LV failure, worsening pulmonary edema. And this could be for multiple reasons. Maybe the ECMO flows are too high, or maybe the heart is failing. And the treatment for this is to give the patient inotropes in order to encourage forward blood flow, decrease the RPMs of the circuit or of the ECMO machine, or to place an Impella, which is a type of percutaneous VAD, and we will talk about that next. Feel free to come back to this talk later, and you'll see what that means. I'm going to leave it alone for right now because it's not the focus of this talk. The other mixing cloud issue that you run into is when the mixing cloud is too distal. And this, again, usually is not a problem as long as the heart, or as long as the lungs work. It becomes a huge problem if the lungs fail. Because, like we said earlier, if deoxygenated blood, if the heart is pumping deoxygenated blood and the mixing cloud is distal to the left common carotid artery, the brain will be getting pure deoxygenated blood, and the rest of the body will be getting oxygenated blood. This is called Harlequin syndrome, or a north-south syndrome. It's a kind of a complicated concept, but testing for it is pretty simple. You just take different pulse ox and PaO2 readings from the upper and lower extremities. It's very easy to diagnose. Fixing it is harder. So fixing it is beyond the scope of this talk. What we'll just say about it is that the easy solution is just to turn up the flows, right? Turn up the ECMO flows and move the mixing cloud closer to the heart. If you can't do that, or the situation is more complicated, you might have to convert to VV ECMO, assuming that the patient's heart works again, or convert to VAV if not both the heart and the lungs have failed. So feel free to watch these talks again. It's a very complicated scenario. If it takes a little bit of additional outside reading for you to fully get it, I wouldn't be surprised. And this is not easy material. So with that, we'll move on to medical complications. Medical complications are again related to the inflammatory response caused by blood circuit interactions. The first is vasoplegia, and the main difference one of the main differences between VA and VV is you don't see the vasoplegia issue enough, and this is because the dominant shock phenotype is a cardiogenic, not distributive. So you just really don't see it as much due to the circuit interactions. Next is bleeding, and this is kind of the same as VV ECMO. You really want to watch for bleeding in the head. Other than that, it's about the same. You will see more bleeding in VA ECMO, probably because the patients are cannulated under emergent conditions and they're generally sicker. Thrombosis is also different. The etiology is the same, but the clinical presentation is very different. VV ECMO, you tend to see most of the thrombosis in the circuit, so in the oxygenator. In VA ECMO, you see most of the embolism in the patient. So this is because VA ECMO the outflow cannula empties into the arterial system, whereas VV it exits into the central venous system. So you don't have the lungs to act as a filter for you. And so what you generally see is strokes, mesenteric ischemia, or emboli to the extremities. And so the chronic presentation of at least the emboli to extremities and mesenteric ischemia is like a sudden unexplained lactic acidosis. Strokes obviously will have focal neurologic deficits, and these are issues that need to be bumped up immediately. So you need to wake up the vascular surgeons, wake up the general surgeons, wake up the cardiac surgeons, wake up the neurologists, wake up everyone. These are emergencies that will kill the patient in less than 12 hours. So do not feel guilty about escalating if you think this is going on. And then last, we'll just talk about some cannula complications and kind of bring it all together at the end. So one of the cannula complications that we often see is a leg ischemia. And this is because because the cardiogenic shock is usually the dominant shock phenotype. You have a combination of poor anterior grade flow, partially from the shock, but partially because the ECMO cannula shoots blood retrograde. If the femoral vein is cannulated, you're also going to have poor venous drainage. So this is a kind of a perfect storm of having a poor perfusion pressure and developing ischemia. What you generally see is a pulseless cold blue foot. Usually it's the legs because the VA ECMO cannulas are usually in the femoral vessels, and the treatment for this is going to be a distal perfusion cannula, at least on the arterial side. This is a additional, I guess, tube that goes from the main cannula into the profunda artery, and it will help increase the antegrade flow to the leg. The leg ischemia is usually seen in shorter patients, women who are on pressors who are emergently cannulated, and this is just because they have smaller arteries, and it's just a matter of size. So the smaller your arteries and veins, the more likely this is to happen. Compartment syndrome is kind of the last complication that we're going to talk about, and it's kind of like the end complication of a extremity embolus combined with this ischemia. What will happen is that the leg will become congested, swollen, and blood flow will be cut off. The tissue will then become ischemic and die. When that tissue dies, it's going to release a lot of toxins in the blood, causing a very severe lactic acidosis and distributive shock. So, how to do once this happens? You have to call surgery. Some hospitals it's ortho, some it's vascular. They have to come and cut open the fascia in order to relieve the pressure. So these are pretty nasty looking wounds, but this compartment syndrome we try to avoid at all costs by recognizing a leg ischemia early and arterial emboli early in the process. It's not always possible, but compartment syndrome will make life a lot harder, so we want to prevent it as much as we can. And finally, we're going to do some wrap up in comparison to VV ECMO. So VA ECMO, you generally see less vasoplegia, and this is because cardiogenic shock is the dominant shock phenotype, and the distributive shock or vasoplegia is probably there. You just don't see it as much, or it's just not clinically meaningful. You see more circuit you will see less vasoplegia and less circuit thrombosis because there's a venous to arterial flow, not venous to venous, and you will see less chattering as well. And I don't have a good reason for this, but chattering arterial cannulas I've never seen, or chattering VA ECMO cannulas I've never seen, whereas VV I have seen. So not to say it doesn't happen, I'm sure it does. It seems to happen less. For VA ECMO, you will also see more bleeding. This is probably because patients are sicker at baseline, and cannulation is done under more emergent circumstances. You'll see more patient emboli, and this is because you have this venous directly to arterial blood flow, so the lungs are not there to act as a filter. And you also see more extremity ischemia, and this is again because the dominant phenotype is cardiogenic shock. You have an arterial cannula that's going to prevent antegrade flow to the legs, and or a venous cannula that will prevent venous drainage. So all of these things combine to make extremity ischemia more common in VA than VV. All right, and that's all for VA ECMO. Finally done.